I'm very excited to introduce Dr. Shazam Hussain, who's from the Cleveland Clinic. He heads the Cleveland Clinic Stroke Program, and he's an assistant professor of medicine and neurology there at the Cleveland Clinic, and he is going to talk on the Cleveland Clinic Mobile Stroke Treatment Unit, taking stroke care to the street. So please help me welcome Dr. Hussain.
Good morning, everyone, and thank you very much for the invitation to come to speak. Well, again, thank you very much to the organizers for inviting me to give this talk today. These are a few of my disclosures. Especially I want to recognize the Maltz family in Cleveland who were generous enough to donate the money, the funds to basically build our mobile stroke unit. And we'll talk a bit about this morning. I want to share our experience with the mobile stroke unit. I'm going to start off briefly with an overview of how the Cleveland Clinic is approaching distance health or telemedicine services that we're going to offer to our patients. Talk a little bit about our telestroke program, which is our first venture into telemedicine, and then really try to spend most of our time on the mobile stroke unit. You know, it's a very, very exciting time, very, very interesting time, and I think exciting time in medicine. We're certainly in a very much a changing landscape where, you know, there's concerns about cost, declining reimbursements, and really this transition that we're doing from volume-based care to value-based care. And we certainly believe very strongly at the Cleveland Clinic that telemedicine is a very important component of how we're going to transition from this volume to value-based care delivery. So briefly, again, what is distance health for us? It's really, very, very simply, any care delivery where our clinicians are not co-located in time or space with the patients or another clinician that they're interacting with. And really our vision at the clinic is that we can virtualize the practice of medicine really to help drive value where it makes clinical and economic sense. And that really is in keeping with our overall integrated care model that we'd like to offer, all the way from patients from their homes, all the way through hospital stays, outpatient facilities, and getting them back into their homes and communities. And so why is it important to develop this capability? Well, again, it comes back down to value-based care, value again being outcomes over cost. We really think we can increase efficiency using telemedicine and help. It really can be a much lower cost as compared to having facilities or hiring physicians at each of these different sites. Really, it's also very much in keeping with where society is going and where patient expectations are. We know that patients and families have much more ready access to the internet. Everybody these days has a smartphone. And they really want a lot more accessibility in terms of their healthcare services. For us at the clinic also, it allows us to really become more so a worldwide organization. We can expand our access really across the world, and it becomes at a very, very low cost. All of this, again, preparing us for capabilities for this value-based care transition. Overall, when we talk about distance health, we're really dividing it into two major areas, that of synchronous versus asynchronous. Asynchronous things are where there's not a direct patient-physician interaction, things like remote monitoring or remote imaging uploads. And then the synchronous activities, things where we actually have a direct interaction. And this can extend anywhere from the outpatient space to the inpatient space. And really, there's a lot of variety of different platforms beyond the scope of this talk today to go into all the different methods that we can offer telemedicine services. But really, nearly every interaction in medicine could be offered in some way, shape, or form through these virtual visits. Turning our attention to stroke then, again, stroke is one of the most significant problems in the United States, and actually it gets a little bit under-recognized. It's overall the 5th leading cause of death, and more importantly, it's the #1 cause of disability. And the reason why that's important, in addition to being obviously a big problem for our patients, is that it becomes a major driver of healthcare costs. It's estimated somewhere in the order of about $80 billion a year is spent related to stroke. And it's important to remember as well, this is no longer an untreatable disease. There was a time there when people really thought it was, but we really do have very, very effective treatments for stroke. Whether it be intravenous TPA, where we can give that through the intravenous, if patients present to us within 4.5 hours of their onset of their stroke. And of course, very, very exciting, recently we've had the publication of 5 randomized controlled trials that have shown that for some of the most severe types of strokes where you have a very large clot sitting in a major artery, we can use new devices, so for example, these stent retrieval devices, which will then allow us to open up these blood vessels in a very quick and efficient fashion. One of the major concepts in stroke is that this time is brain. You'll hear this a lot if you listen or talk to stroke people. And that's because it really is perhaps the most time-sensitive condition in all of medicine. It's estimated we lose somewhere in the order of about 1.9 million neurons per minute in the situation of acute stroke. And I think everybody in this room would agree that we want to keep as many brain cells as we can. So really it is a disease where every minute counts. And very, very important we keep that in mind as we're trying to organize systems of care and design how we take care of these stroke patients. So where does telestroke fit in? Well, unfortunately in the United States, we're still in a situation where we don't do a great job of treating acute strokes. Overall, if you look nationally, it's only about 3 to 5% of patients that are administered the intravenous TPA. And there's been a good development of systems of care, particularly through primary stroke centers and now comprehensive stroke centers. These are centers that really are equipped with the resources and personnel to deliver these therapies and provide adequate care for stroke patients. But overall, they still represent only the minority of acute care facilities. And one of the most major limitations to this is the access to rapid neurological consultation. Well, we can really offer a good solution for this through telemedicine, where really our experts at major centers or those with stroke expertise can offer, via this virtual interaction, improved access for patients at oftentimes remote sites from major centers. It offers us the opportunity, excuse me, to offer more patients acute stroke therapy, and it also comes again at this low cost. Oftentimes you can actually argue that perhaps it offers even faster therapy, especially if you think about after hours where a physician may be at their home and would have to normally drive into a hospital to come and see a patient. If they're able to virtually come into the situation, that can offer a lot faster therapy for our patients. And we do also know there's some good data out there that really the assessment of patients via telemedicine is more accurate than the traditional way of oftentimes just trying to get a representation of what the patient's like over the telephone. And so, various systems are out there. This is an example of the InTouch system, where you have a robot, and then, of course, on the screen there, the patient and family and other physicians on the other end can see and interact with the physician based on the screen and video conferencing capabilities. On the other end, where the treating physician is sitting, they have these video monitors where we can see the patient and interact. Also have access usually to a PAC system, so we can view any imaging and other data that's coming from the spoke hospital. And it's becoming a lot more portable as well, which is important for physicians who do these type of telemedicine. Before, you were kind of tied down to your home or you're sitting right in front of your computer, but now with the advent of laptops, better laptops, smartphones, and tablets, we're actually able to be a lot more portable, and so you don't have to feel that your life is very restricted when you're doing these consultations. So, typically how would this process work? Well, a patient would come to the local emergency room, get identified as a stroke. They're going to get their initial assessment and be sent on for their CT head. At the same time, the emergency room physician, once they've made this assessment, is usually trying to contact then the hub hospital and try to get the stroke specialists, tell them about the situation. And then within minutes of that interaction, usually that CAT scan is going to be completed. We can then come into the situation via this telemedicine link. Then, of course, through the telemedicine link, we can interact with the patients, clarify some things about the history, do our examination, usually with a nurse or ED physician on the other end. Again, I have the capability to review CAT scans and other important information that will help us in our decision making. And then, together with the ED physician, we can then actually even counsel patients on the other end. We can talk with them, tell them about the risks and benefits of treatment, and then initiate treatment if they are appropriate candidates. The other major advantage of using telestroke is that, as opposed to traditional systems where patients are often transferred to the major centers, it allows us to keep certain patients out at their spoke hospital, which is much better for their care, because patients tend to recover much better when they're in their local communities. And so, really, with those patients where that hospital has the capability to take care of those patients, and again, with the telemedicine, it's not just a matter of the video link, but there's a whole system that goes around that, where we interact with the hospitals, help enact protocols to help take care of patients. But we really can try to keep most of our patients at these hospitals. Of course, there are going to be certain situations where there's more severe strokes, where we're going to need to perhaps bring those patients to the more major centers, and those transfer algorithms will often be in place. And so, looking at our Cleveland Clinic network, we cover a series of hospitals in our northeastern Ohio and western Pennsylvania area. Overall, we've seen a steady growth over the last several years, especially in 2015. We've now expanded within our own enterprise to offer these capabilities. And you can see here with 2015, it looks like we'll be coming very close to nearly 1,000 consultations via our telemedicine system. Again, if you look at the number of transfers, though, only about 1/10 of those are getting transferred, which means we're able to take care of these patients in their home hospitals. And then, again, getting patients transferred for intervention. We're seeing a decent number of those patients coming, again, the most severe strokes, getting them to the care that they need. Looking, importantly about, how are we doing in terms of administering TPA? I've been saying that we use this to help improve our access for these patients and deliver more of these acute therapies. We've been seeing this very much so in our Cleveland Clinic network, that we've substantially increased the number of patients getting intravenous TPA, doubling it, or even some places increasing it, many, many fold. We've also been able to track outcomes in these patients. We are able to do this safely without any real differences, any kind of complications from the therapy, and we are seeing substantial improved outcomes from these, being able to deliver this care to these patients. So going forward then, the next evolution for us at the Cleveland Clinic in terms of stroke care, once we had our telestroke capabilities, was to see, and we had heard data coming out of Germany about patients, about these ambulance units that had CT scanners on board. And really, I think Dr. Hill, who's out of the University of Calgary, made a very, very nice statement that we really can't expect a patient's disease biology to match our systems, especially with stroke, because the time window for treatment is so short. We really need to match our systems to the biology. And I think the mobile stroke treatment unit really fits very, very well with that concept. Because the time window is so short, it naturally makes sense for us to try to go out to the patients to try to deliver their care. These are the two units that are existing in Germany, one at the University of Saarland, Professor Fassbender, who was the first in the world to initiate this concept. And then Berlin also, over the last several years, they've been able to show through a randomized week-on, week-off design that they were able to substantially reduce time to treatment, decreasing time to treatment of an average of 40 minutes in these situations. And again, what they recognize there, as we do in the field, is that really the critical stroke treatment decision, you can't make that decision until you have the CAT scan. And so obviously, if someone has a bleed in their brain, that's going to be a situation that's going to require much different care than those who have a blood clot type of stroke or ischemic type of stroke. Obviously, if they have bleeding in the head, that's a situation where you really don't want to give the intravenous TPA. That can be very dangerous and potentially fatal to a patient. And really, unfortunately, until you have that CAT scan, even the best neurologist in the world will never be able to tell between a hemorrhagic type stroke and a ischemic or blood clot type stroke. So really, again, after going to Germany and seeing this, we launched our own mobile stroke treatment unit. Again, the idea is not to wait for the patient to come to the emergency room, but rather bring the CAT scanner and stroke expertise out to the patient in the field. And we were able to, it's basically a specialized stroke emergency room on wheels. We were able to do the assessment of the patient, get all the information we need, and actually initiate treatment, for example, intravenous TPA, right there in the field. Really, this will dramatically cut down our time to treatment decisions. So this is the inside of the ambulance. You can see there's a CAT scanner on the top picture. And then if we look from the head of the bed downwards, you see this is the point-of-care lab testing that we have. And then from here, this is the InTouch RP Express. It sinks down on a little arm once we're ready to beam into the vehicle. And we are actually the only unit in the world presently that solely uses telemedicine and teleradiology for the care. All the other units in existence actually have a physician on board. I'll come to that in a little bit, but I think in terms of a driver of cost, having the telemedicine capability, again, makes this potentially feasible as a cost-effective strategy to treat stroke. The CAT scanner that's on board the vehicle is a Ceratom. It's built by Neurologica, 8-slice CT scanner that's able to scan the head. We've actually used this in our neurologic intensive care unit for a number of years as a reasonable quality, especially for the purpose that we need it for, which is to detect, is there any blood in the head or is there not? I think that's important to keep in mind when you're trying to look and make decisions based on this scanner. Telemedicine, as I mentioned, is using this InTouch RP Express. Data has been out there about telemedicine interactions, showing that really the reliability is pretty good. You can get good CAPA scores. Houston did with mock patients, we were able to get very, very good absolute agreement. Really, the limitation for this technology in the previous years has really been reliable broadband. A few years ago, Berlin had tried to do this and only found they got 18 of 30 technically successful connections. But of course, they were running on older broadband technology. Really, the real thing that has launched this, I think, mobile stroke treatment units forward has been the advent of really 4G, LTE, these high-speed networks. So we've partnered with Verizon to be able to offer this to help really maintain a very good and accurate telemedicine link. So our mobile stroke treatment unit services the city of Cleveland. It's about 33 miles across, 77 square miles, with a population of about 350, 400,000. Of course, during the daytime with workers coming in, it swells up to about 800,000. And we service all within those borders. How does it work? Well, basically when a 911 call comes in, the dispatchers do have a normal algorithm that they work through to allow them to identify potential stroke. And if they identify that, the dispatchers will actually co-dispatch our ambulance along with the mobile stroke treatment unit along with a Cleveland EMS vehicle. Cleveland EMS, because they're all over the city, they're typically going to get to the scene first, be able to assess and make sure the scene is safe and do a preliminary assessment of the patient. Oftentimes they'll get there, and if it turns out to be something that doesn't look like a stroke, they'll call us off, but otherwise we'll arrive on the scene. So again, just to look at it from our end, again, we're sitting at our workstation, we're able to view, and the nice thing, we can view these CAT scans. You can see again the quality. There can be some artifacts at times, but we've actually done a lot of improvements to the head holder and other things to improve that quality. You can see here we can even pick up things like hyperdense MCA signs, things that can be very helpful in the decision making. And we also have the very nice things. We have access to the electronic record. If they've been in our healthcare system, generally speaking, we can see what medications they've been on, which can be very helpful oftentimes in a situation where you're not going to get a lot of history from either the patient or witnesses. Again, there is a transport algorithm that allows us to then decide which hospital to take the patient to. And just to share a little bit of the data then, looking at our times to treatment through the course of this last year, nationally we do have this national target. So from the time of a 911 call to when EMS personnel want to deliver the patient to the hospital, they give themselves about a 20-minute time frame to do that. And then once they hit the hospital, we have what we call a door-to-needle time, door to the hospital to administration of TPA in 60 minutes. So you take that as an 80-minute target. So if you look at our times, if we take from the time of the 911 call to when we're treating on the vehicle, we've settled out at about an average time of about 40 minutes, which is saving about 40 minutes of time from what this benchmark is. Remembering, of course, that nationally only less than half of patients are actually treated by that benchmark time. So really for us, this has been a great win. We've been able to treat patients much, much faster than we would been able to by traditional models. Looking at it in another way, if we look at the last known well time to thrombolysis, again, this obviously involves a lot of factors about whether patients call the hospital and how quickly they can get there. But traditionally, if we look at controls from our own healthcare system, we were generally treating patients out towards past 1 hour up to about 4.5 hours. We've seen a shift. If you look at those gold bars, we've shifted that much more earlier since their last known well time, including treating a quarter of the patients, and this was in the first 100 patients. 16 patients got TPA. 4 of them were treated in what we call the golden or platinum hour, the first hour after symptom onset. This is very consistent with what we've seen in Germany, with much large number of patients being treated earlier in that very early time window. Telemedicine, as we mentioned, has been very reliable for us. We did have a few dropouts. Most of them are brief and don't affect clinical care. 2 of them were a little longer, and sometimes what they can do is just move the truck about 10 feet and you can get a better signal, and that'll help us restore it. There was one situation where we weren't able to get signal back, but again, having that specialized crew on the truck that really is very, very well versed with stroke, by communicating with them on the telephone, they were able to get a good assessment of the situation. We immediately came to emergency room, and as opposed to where we have to start from scratch in that emergency room, we already have a lot of information which allows us to give treatment a lot faster. Again, the real key here is using this mobile technology, the 4G LTE networks. And just to wrap up then, it's important also to remember that this isn't just about IV TPA or treatment of ischemic strokes. We can treat a variety of neurological, and I would argue actually non-neurological conditions as well with this type of vehicle. Example is with intracranial hemorrhages. We've been able to do things like blood pressure lowering. And in fact, there was a case we had where a patient was on blood thinners. They had an elevated INR test, which reflects the degree of blood thinning. We were actually able to give them a medication called Kcentra, which can reverse the effects of the anticoagulation. By the time they arrive at the hospital, 10-15 minutes later, they are completely reversed from their blood thinners. And so again, for that patient, that's a huge benefit because you can really prevent that blood bleeding from continuing and potentially producing a worse outcome. The other important aspect, I think, of this that has not been talked about as much is that really it allows us to get to the patient to the right place the first time. And so we know from these large vessel type of strokes, the more severe strokes, oftentimes they are going to the closest hospital but then require a second transfer. You can get to the first hospital very, very quickly, but going from hospital to hospital actually takes a good amount of time, on average about 3 hours. And so we had an example of a case where we saw a more severe stroke and actually bypassed the closer hospital to get to the interventional capable center, and we're able to save that 3 hours of time. And so again, we're talking about 2 million brain cells a minute. If you can save 3 hours of time, that's going to be a huge impact to these patients. So, there's a lot of work being done around the world with these mobile stroke units. In fact, in Norway, they're looking at putting a CT scanner on a helicopter. I was just telling Dr. Albers that he should be looking at this at Stanford. They could use that when they fly their patients in. But there's a lot of innovation going on with these mobile stroke units. So we'll see if the Norwegians can get this thing on a helicopter. But around the world, there are multiple centers that are working on this. The ones in purple there are the ones that have established stroke units, 2 in Germany, 2 here in the United States ourselves and in Houston. But a number of places are very close to being able to get this off the ground and up and running. These are the pictures of the 4 that exist around the world, 2 in Germany on the top, and then our unit and the Houston unit on the bottom. But I really hope that I've been able to illustrate that we've been able to result this faster time to evaluation and treatment. Really, again, we're trying to get patients to the right place the first time. We're still going to need to do more work in terms of establishing outcome improvement as well as cost effectiveness, but really the signals are very strong in that direction. So I'd like to acknowledge my colleagues. We've created this FAST study group to help answer some of the important questions that are in existence there, and happy to take, I guess I'm close to my time, but if there's a question or two, I'm happy to take it, so thanks.
All I can say is that's really, really cool.
Thank you.
Actually, I have a question.
Sure.
What do you think the scalability of this concept is? So for example, you have one in Cleveland, and if in terms of, obviously it's a more costly system, what's the right ratio that you think ultimately would be an appropriate balance between the speed and the cost?
Yeah, it's a great question. I think we're hopefully doing some analysis now to help understand that. But to cover the city of Cleveland right now, because we're trying to do our expansion, we were in the city of Cleveland proper, we're trying to go into the suburbs. To cover the city of Cleveland properly, I think we're going to be looking at probably having 2 units, one on the east side and one on the west side. And hours of operation right now are 8 a.m. to 8 p.m. I think we need to expand the hour of operations. So, but if you can do that, in the German data, again, their system's different, so we have to do our own analysis based on the U.S. system. But they were projecting that basically 1 unit would probably service about 500,000 people was their estimate. So
great. Thank you very much. We have one question.
Thank you. Matt Gwynn from Atlanta.
Hey.
How do you determine where to send this unit? For example, who makes that decision that unit's going out instead of something else? And as a corollary, how many stroke mimics are you seeing when you do this?
Great question. So we're the 911 dispatchers already had a stroke algorithm that they used with dispatching EMS, because if they see that, the EMS guys want to move quickly, get that patient to the hospital right away. So what we do is actually co-dispatch with that Cleveland EMS truck, so both units are sent out. Cleveland EMS will get there, and about 2/3 of the time they'll get there and they'll find out it's something else. Like, we've had a lot of cases actually, dispatchers, when they hear there's a history of stroke, they'll identify it as a stroke, but it turns out to be abdominal pain. So obviously our services are not needed there. They'll tell us, call you off. We don't need you. Get ready for the next one. And in doing so, that method, we've actually had not too many simultaneous calls. Obviously, if you're on a call already and your resource has already been dispatched, you basically have to go to that. And so that's just the situation that you're in. When we get to the scene, though, usually we hand off the care. And if we look at our first 100 patients is where we really have analyzed the data. We're looking to do up to 250 for the next stroke meeting. But in that group, there are about 1/3 of them turn out to be stroke mimics, but half of those stroke mimics are actually neurological conditions. So we've seen seizures and other conditions where I think some of those conditions actually had the benefit of having our expertise right away on the scene. So,
What would you do if you were on the 405 in Los Angeles at Friday afternoon?
That's why you need the helicopter. So,
Thank you very much.
No problem. Thanks, guys.